All right, good morning for myself. God, how do you say it? God after dog. Is that Swedish, right? For good afternoon. God after dog.
No, good, yeah, good eftermiddag.
Good afternoon.
For us, it's late afternoon or very early evening.
All right, well, welcome everybody. Here we are at ADR, TDR Facebook group. We have two people with us today. I'm so glad to see you both. We have Dr. and correct me if I say it wrong. Is it Svante Berg?
Svante Berg, yeah.
And Maria, I forget your last name.
Maria Thorander.
Thorander, that's a very common name for Swedes. But anyhow, welcome. My group is so excited to ask you round two of our clinical questions. And what I'd ask is just a little introductions about yourself, where you lived, your schooling, if you want to do, how long you've been doing this. Dr. Berg?
Yeah, I'm orthopedic surgeon since 83, educated at Karolinska Institute in Stockholm, where I'm born. I've done solely spine since the same year, 83. And since 95, I've done a lot of total disc replacements with different implants as time has passed and they have developed. I'm also an associate professor at Karolinska Institute since I is fairly engaged in science and scientific studies, except from clinical work that still is going on and is by now almost 100% anterior surgery in the lumbar.
Maria?
Yes, and my name is Maria Thorander, and I am a Swedish physiotherapist and educated in Oslo, Norway. And I am quite old physiotherapist nowadays. I have my 25th century celebration next weekend in Oslo. So I've been working since the 90s with neurology and orthopedic patients. And I work together with Svante now for 16 years. And thought when I continued my studies at Karolinska Institute and took my master there, that the front surgery was interesting, and particularly the disc replacement surgery, and have seen a lot of patients there during these 16 years. And during these years, it sort of has developed a protocol for how to prepare yourself for surgery and how to treat your back postoperative after the surgery. And that has been a great, I would say, success in helping the patients to return to all the physics that they want to do. And it's really, really interesting to see how important the protocol and the exercises that they do, what impact it has before and after surgery. And it's a tough one, but very good and important. So that's what I've been doing and developing, and we learn by the patients. So the more we meet them, and we have seen plenty of them during the years, you still continue developing this program, but it's very interesting and very nice to work with this kind of patient that wants to come back to increased physical activity.
And we in the group, just to let our people know, we have your videos loaded onto our group, and you can find them under Maria. And she's got 4 different videos, and they are in Swedish. And then one of her patients, Katie, came through and went through and did them in English. And we'll kind of revisit those and put those back at the top, for that way people can find them again and make it a little bit easier to find them. And Dr. Berg, how many disc implants have you done today, as of today, would you guess?
Well, I haven't summarized after today. That has been a day at surgery, but I'm far beyond 7,000 patients, and that means maybe 12, 13,000 implants. And I've done it since 95 then.
And let's go into some of those implants, because we've talked about some of the implants you've used, and one of the questions that some of the people have is, and personally, what disc have you seen fail personally in your practice that you had to fix?
I used very little charity. I used it early on when I had nothing else. I know they can fail. I've had one that went out backwards, a charity. It was no disaster. I could pick it in and make an A-lift, but it was not a wear out. It was more or less that the polyethylene subluxated posteriorly. Then I used for a long time the Pro Disc that still Batagnoli uses since he sells them. And that was the best one in the late 90s. It was a ball and socket design. And then we had the Maverick that was also ball and socket design, but in total metal without the polyethylene. I used them parallel for some time. And then came the 3-piece devices. I did a lot of kineflexes in the first, between 2005 and 2010 or so. And that is a 3-piece metal-on-metal device. And none of these has actually failed mechanically, didn't stand the test of time. I had 4 patients with metal issues from either Kineflex or Maverick, developing spinal stenosis that had to be treated with decompression and fusion of the segment so it didn't move and produce any more nanoparticles. And about 2010 or 11, I don't know exactly the year, I started using another 3-piece device called Orbit from a US company called Globus Medical. It's not FDA approved since they haven't even tried. But it's fairly similar to Kineflex, but it's peak on peak on peak. So I wouldn't risk any more metal problems. They have changed a little of the design, so it's not a pupil both upwards and downwards. It's a cylinder downwards, so it allows for translation back and forth, but not sideways. So it was a little another step. For a while in the 90s, I was part of trials with a prosthesis that Stryker achieved called FlexiCore. It came and went. It didn't break down, but the construction was that there were no low enough discs. So when I used it, I could just use it for huge people. So that was a short visitor in my wardrobe actually. And then some years ago, I started to use the only, to me, appealing viscoelastic prosthesis that appeared. I never went into M6 out of different reasons. I don't want to speak bad about that, but there were some reasons I didn't go into that. And in Europe now, M6 is less and less used because it has problems with standing the test of time. But I still thought that the old dead Professor Roy Camille in Paris said, the disc is not a joint, it's a cushion. So it was very appealing to me to use something viscoelastic to bring this type of surgery a step further.
And one of the things that I think people we haven't discussed, and maybe we do this in round 3 if you like, you're probably one of the most well-written doctors or surgeons out there. I mean, how many papers have you written in the past 30 years?
I think I published about 35.
Yeah, I mean, there's a whole bunch that I've read through, and each one is just as impressive as the other, but maybe with the next one we go through some of those papers. I don't know if it'd be worth it or not, but that's one of the things that always impressed me is that you are well written, and that information and education definitely shows through your practice. One of the things that I wanted you to talk about was the advantages and disadvantages of ball and socket and elastoprosthesis design. So maybe you wanted to kind of elaborate on the advantages of both. The one thing that we know, the one advantage of, say, example of a pro disc is in the Maverick, is that they don't move after. And you've seen a few ESP move after surgery, which was kind of surprising, but it happens, and that may be more patient issues there that weren't following the protocol. And I think he knew that he was doing some things probably too early on, but we can talk. Would you like to kind of go in discussion with that?
Yeah, I'd like to do that. First of all, I'd like, if we talk about mechanical prosthesis, what you consider today is three-piece devices. No simple Mavericks or Pro Discs are actually, they are old-timers now, because the three-piece devices allows for some translation. But with Pro Disc, I've had 2 cases where the polyethylene has luxated anteriorly, and I've had some patients sent from Norway and Germany with the same problem. So even if the prosthesis is fixed to the vertebrae, the polyethylene can slide, but it's very, very rare. And if you put the Pro Disc off midline, the polyethylene might wear, as in Charité prosthesis. But coming to, there are definite advantages of mechanical prosthesis. You restore mobility, but the mobility is without any limitations from the prosthesis side. The patient had to provide the limitation of mobility, meaning to keep a balanced spine. It's something that is up to the muscles to take care of. They have to have strong enough abdominal muscle and not too strong low back spine muscles, and they are always strong when you have pain a long time. So the issue with mechanical prosthesis that they, in patients, especially somewhat lazy patients that don't want to do Maria's programs enough, they might tilt over and develop a segmental hyperlordosis, we call it. They end up in a non-physiological lordosis hanging on their facets. And then there is a clear risk of developing facet joint arthritis. But the other hand, the stresses on the end plate, when you place it the first period before a bone grows in and so on, is very low, since there's no mechanical constraint in the process, in the prosthesis. So subsidence is absolutely less likely to happen if you don't have osteoporosis or something like that. If you compare that with a viscoelastic working prosthesis, since it has built-in counterforces to movements, it's not so dependent on what the patient has to balance their spine all the time. The prosthesis help them balance their spine, help them avoid developing segmental hyperlordosis. But on the other hand, is more demanding in the early phase after surgery on the end plate. Whether you have a little injury to the end plate during surgery, or if you're unlucky, the forces on the bone prosthesis contact area are much higher with a viscoelastic prosthesis. After a while, bone grows stronger where it's under pressure. So this is a early on problem. I've had one patient with a small subsidence, and that happened very early. And as I see it from this group, patients that have subsidence, I think it happens within the 2 first months. If it hasn't happened then, I don't think it will ever happen, because then the bone has stocked up underneath and above the prosthesis to take all the stresses and forces, and then you start having all the advantages of a viscoelastic prosthesis.
So, you know, a lot of people aren't familiar with Wolff's Law. So, you know, Wolff's Law kind of comes into play with that prosthesis. Once you place that prosthesis in there, it's the same way when you break a bone. You break a bone, that area where that bone is broke is going to be much harder. You're never going to break that bone again. So the theory is that I think you're saying is because of the way the bone remolds, it's going to be much stiffer and harder where those end plates are touching, correct?
And we can see that it's like when you work in the garden without gloves, your skin gets tougher. The
Right.
same happens with bone. And I have, since I've done this now for 25 years, I have patients that have grown very old. And even if their bone quality decreases through age, you look at their x-rays, underneath the prosthesis and above, the bone is very thick and sclerotic because it's always under stress, so we'll never decalcify there.
Yeah, I think that's one of the big questions that we see over and over again is that, yeah, what happens when I'm 70 or 80 years old? What's going to happen to my bone? And you're one of those people that fortunately are seeing those patients, 20 years later, because you treated them, 20 years ago and they were 55 or 60 and now they're, 75 and 80, and you're still seeing no subsidence. You're not seeing any type. I guess one of the next questions that we can kind of go into are those, one of the things that we hear is you'll hear ossification. We know it doesn't happen as much in lumbar, but have you seen that with some of the older type generation discs? And then, maybe through bad placement, possibly, or do we see not a failure, but maybe the disc isn't moving? I mean, we know that some of the M6s out there, they're holding up, but they're not moving at all. And we know that there's one fella, there's a couple people that have an ESP, and they were kind of told that's probably not working as well, So I guess what your theory? Do you still think there's any type of movement in there, or it's maybe just a really hard, soft type fusion where it's just moving very limited, but still moving a little bit?
I've seen, of course, since I got these large materials, I've seen patients that on normal flexion extension pictures, after, especially in the long term, like 2-5 years, doesn't move. It's been especially the charity, actually. I don't know if my surgery was worse at that time or if it's something that was dependent on the prosthesis. But also in the very large German charity follow-up, they were not compared to anything, but they had quite a number of spontaneous fusions. They were done surgically in the 90s, where we were not so cunning how to do this. And I think presently it's a minor problem, but you should never, since I never create any bone dust in this surgery, bone dust left is known to be able to start this process. And I don't attack bone at all. So there is no bone dust from the surgery. And these patients start moving when they are in the recovery room. They start to do the frog and this and that not to keep movement of the processes, but to take care of contract spine muscles. But they start moving it immediately to its limits, unloaded, lying down. And that means that I'm not afraid that it would subside by that, because that I would have noticed when I put it there, but they start moving immediately. But then you might have mild bleeding or whatever that calcifies after surgery, and that might create a future fusion. So I think you can never be certain that this won't happen. But by thorough surgery, we can avoid it frequently.
So thank you. So let's move into some of the people probably aren't familiar with, when you're trialing your disc. So, you've cleaned out the disc space and you haven't created any bone dust. You probably have a little bit of bleeding from the end plate, so hopefully not much. And then you say, okay, do you typically know the size that you're going to go with prior, or is it more like, okay, I think from being in there that I'm either going to go with a 10 millimeter, I'm going to go with a 12 meter, and then how do you figure out your lordosis? I mean, do you usually get it right every time, or is it kind of trial and error where you're putting one in, it's not snug? Can you kind of walk us through that?
Well, yeah. Let's say that when I prepare the disc space, I have the possibility to have an educated guess. What I do to clean out the disc space is that I distracted some, and then I feel the length of their ligaments surrounding the disc at sides. That gives me a fairly good figure of how high was this disc from starters. But sometimes you're not on that certain. I always try. Today, for example, I had a guy, he's 179. I did 2 A-lifts and 1 disc on him. And I tried with a 10. It was the lowest segment was with a disc, 10 millimeter maximum angle, since it's lumbosacral, it should be. And then I went to 12 and I felt, no, 12 is too high. And I went back to 10 and I placed a 10 millimeter. So, I mean, I have all the time in the world and it's prepared, and it's, I mean, I could try 50 different sizes if I had, but I don't have that many. But of course, most frequently I go for the one that is going to be from starters, since both my educated guess had done this so many times, but especially having prepared that disc space gives me a feeling for what size has it been.
Okay. And Maria, maybe you could kind of weigh in on this. Some of the females asked pregnancy after surgery, after this surgery. Is there any type of complications that they could have? Is there anything that would prevent them from having a pregnancy?
No, absolutely not. And I would say that I really don't hear from the girls that continue their lives with having children and things like that. Once in a while, I can get an email. Is there anything I should think about or do or so? But I would say that they are so good educated in themselves with this hard, tough training that they have done during this year with this surgery. So they know that maybe this little increased belly could increase some increased lordosis, but it doesn't affect them. So no, I won't say it has an impact in that way. But of course you get tired like all pregnant women in your body because it changed, but I wouldn't say particularly that they would have that old pain like before and be afraid that they destroy something in the back because they have that. They are doing fine, I would say.
It's actually rather frequent that young females that are in the age for having kids and have a relation, and when they're fine at 3 months checkup, and then when I see them after a year, they are suddenly pregnant, and they say, well, I couldn't have this before, but now my back is fine, so I can have it. So I have a little box here with just photos of babies after disc processes. But in the early years, in the mid-90s, when they came to the, I don't know, delivery department, I was called and they said, oh, I have a mama here, she's going to have a baby and she has this prosthesis. We're going to do a section cesarea, right? And I said, no, why? Doesn't affect normal delivery at all. And it doesn't affect the possibilities to have a spinal epidural or whatever needed. It's absolutely normal delivery. I mean, some girls are too narrow in their pelvis, but that wasn't because of the disc. That's their anatomical shape. But it's normal. Everything works normal afterwards.
So let's flip the question around a little bit. So you have a patient that's had 3 kids and they had narrow hips and they all had to be done by C-section. So obviously there's some scar tissue there. We know you use an access surgeon from the last video. Is there ever an issue getting to the disc area if someone's had 3 or 4 C-sections or some other type of stomach surgery for you?
No, not really. Not especially not if it's been from the gynecologist. The problem with them is that they cut the abdominal muscles, and that's grotesque in my world. But the scarring stops just underneath the musculature, because when they reach the uterus, they don't go further. So that doesn't cause any problems. We have had patients that have had injuries and surgery in the back part of the abdomen that has been scarred, but that is like revising a case. You can always do it, revising from front to case if something happens. It's always possible. You just have to spend a little more time.
Right. And the same thing with the hernia. If someone would have a hernia there in the front, you just go around the hernia, correct?
Yeah, actually, if it's a midline hernia that some mothers might have when they have this muscle splitting, we take the chance to repair it once we're there.
So we get this question a lot as well, and I think we covered this a lot on the last round, but you know, SI joints. Everybody seems to have SI joint problems, whether it's an ESP, whether it's a hybrid, and they've had that area fused. And some people, you know, something we learned is some people may be going on undiagnosed. They had SI joint problems, but they have had, you know, total disc replacement surgery. What do you do in your practice to kind of eliminate all those scenarios? And then if they do have SI joint, what do you recommend that they do? And Maria, maybe you can help us with some therapy questions as well, as you know, and we know it's more females because they're the ones that had the pregnancy that, you know, have had some issues with SI joints, but we do have a few men as well. We do some things, and I mentioned to you, and you said, no, we don't do that in Sweden, but we use PRP, platelet-rich plasma, to kind of go in there to treat those SI joints, and it seems to work here to a point, but it doesn't last. We know that. You can kind of get a year or two relief out of it, maybe max. But maybe you guys can kind of venture on that.
I think it's an epidemic in the cultural world of SI joint problems now. And I think the reason for that is that some companies has developed such good fusion instruments for SI joints, and people want to use them and have their income from using them. So I'm very skeptical. It exists, of course, but it's the frequency in your country, in my country, has increased so much since these instruments came. And I think you should be very sober when looking at this. All these patients with discogenic low back pain have a both preferred pain and a muscular pain going out over the sacroiliacal joints because the gluteal muscles are attached there. And many of them are diagnosed by injections. And of course, this injection also helps where the gluteal muscles are originating from. So it doesn't say that it's the SI joints. It's a very known cause of problems with SI joints is lumbar fusions. The longer a lumbar fusion, the more stress on the SI joints. In the same matter, I think that the more kept mobility or restored mobility eases pressures on SI joints. We treat SI joints surgically here, but we are very, very cautious to do that because it's often a lot of the problems. And we get patients sent here that has been treated to SI joint problems with fusions, and the symptoms are exactly the same, and it ends up with that they are suffering from degenerative disc disease instead. So you have to be very sober looking at it. It exists, but I feel that it's presently overdiagnosed.
Okay. And then Maria, is there anything you would recommend to help with that?
Well, you know, for me, it's a completely different patient when they come and you have that kind of patient, because I would say that for all, they walk differently. If you have that joint problem down compares to the lower spine problem, I have seen videos of patients that have those different issues, lower back pain and SI joint pain. And the one with that SI joint pain, they limp in a completely different way compared to the lower back patient. And I would say it's a small amount of patients that really have the big issues. And I am so old, so when I got to school, I learned that these joints can maximum move nothing or 1 to 2 degrees. So
Or
it's
millimeters. Yeah.
millimeters. So it's absolutely nothing that can move. And that is the way I have been. But, you know, there are different schools and a different kind of sort of fashion in what's in and out with treatment and rehab and things like that. And now it's a lot about that. And I also met those few patients, I would say, that we have had in this clinic with that kind of instrument that they do down there. And it's a completely way of treating and acting, and they have other problems, but and afterwards it takes so much more to come back. So now this it's another kind of patient, and they move different and they act different with the issue. So for me, I can't compare them even.
But even so, a lot of our patients, when they come to us, they think that they have a combination of low back pain due to DDD and a sacroiliacal joint problem, because they've had that diagnosed by some physiotherapist or some doctors using injections. And we just look over the SI joint part, treat the DDD, and then suddenly they don't complain from that anymore. So in our world, it's frequent that the DDD pain projects down to the SI joints.
Yeah.
Okay, going a totally different direction, and I don't think I've prepared you for this at all. So lateral, doing a lateral approach with artificial disc or total disc replacement, do you think it's in the future?
Well, you have to look what's the gain. You'll surely have an economical gain because you don't have to cover the fee for an access surgeon. And that's the most driving part of this, because the muscular damage you do, I've done this, so I'm not an amateur. I've done that mostly with cages, and in some cases, cages is very good for early onset degenerative scoliosis or so on. But to have a disc placed that way, it will be mechanically movable compared to a cage. So, and to have it directly positioned when you come from sideways, it's very difficult. And you're more or less guessing that it ended up in the right place. And you have to, when you go through psoas, as you have to do to come exactly from the sideways, you have some nerve roots there, and it's very easy to irritate them or even harm them. So I think on caging, I'm all for it, because I think for elderly people that start to tilt over, it's a very low trauma thing, because you don't have to put the cage all the way to the PLL. You can put it more or less in front of the disc space and put screws in and a bone, and they're fine. And that is what I've mainly been doing. I think if you go for mobility, the positioning is so delicate. And since I think it's extremely easy to get in from front, since that's what I do. But I know that, especially in your system, where the doctors have to split the fee with a vascular surgeon or access surgeon, or take a double doctor's fee to have that, there's been a very strong strive to develop something that would make the access surgeon unnecessary. And it's not out of medical ideal things, it's more related to how the system works.
Sure. Hope that noise isn't too loud. I get a little work on my house, but let's talk about some patients been coming in, and I know it's very rare, but some problems with the upper levels, L2, L3. So I guess if you see somebody with a bad L2, L3, 3, 4, maybe even 4, 5, for example. So we're looking at 3 levels. Would you do, I would use the word reverse hybrid, but what is your thoughts on keeping stability or fusing at the top or not fusing at the top at that L2, L3 level? Because we've had a few people, or maybe they have a little scoliosis at the top, or maybe a little retro at the top, or maybe the vertebrae shift a little bit. how would you approach, a couple of those scenarios?
First of all, the divider for me, if I'm going to do an A-lift or a disc, is how are the facet joints. For a mechanical disc, they have to be virgin almost. I think for a viscoelastic, you can be a little more tolerable. It might have early slight facet joint affection since you're going to unload it with the prosthesis. And that is actually what makes me decide what segments am I going to do anterior fusion and what segments when I keep mobile. But with a stiff viscoelastic prosthesis, I can, if they are bending this or that way, or if they are tilting, doesn't affect me. I know that I will rearrange that because the tilting then comes from that one side of the disc tilts together and the other one is higher. And when I put in a implant that is parallel, you resolve the problem. So it actually, I'll do any of the lumbar segments. I'll do any of them with A-lifts or discs, but I'll go for each segment I evaluate. Is this a better segment for mobility or a better segment for taking away mobility? But just tilting sideways or this and that or a lattice, if the facets are still healthy, wouldn't keep me from using a viscoelastic. If you have a lattice, meaning sideways shift, normally the facets are gone. And then mostly you end up with an A-lift.
I guess maybe you both can weigh on this. A lot of people, my theory's always been, we know the L4, L5 is the workhorse, right? That's where most of our bending and whatnot, but maybe you can kind of go through each level. Maybe Maria, you may want to cover this, how much load is giving onto each level, because I think some people don't understand the importance that maybe if you do fuse L2, L3, it's not going to be huge, or maybe you think it will be huge to the rest of the back. Maybe it'll cause issues on the disc above or the disc below, or we generally, because there's the one patient I'm talking about, Dr. Berg, and that's where I'm kind of trying to frame this around. For her is that if you fuse an upper level, what's the chances of adjacent segment disease happening on that level above? And I guess would it cause pain as well? And I guess I kind of want to go back maybe to a step is some of these discs do autofuse. Does it cause pain? Because you've probably seen a few patients 23, 30 years that are autofused. Are they in pain or they're fine? They're just maybe a little stiff. So let's start first with the levels and then kind of go back to autofusing. Does it cause pain, I guess?
Who should start? Me or Maria?
Whoever wants.
Yeah, I can, since I know this case, the thing is that, as I said, today I had a case where I did A-lift 3-4, A-lift 4-5, and I put a sac prosthesis L5. It's very uncommon. Yeah. Meaning that this guy had healthy facets on L5 as one, but he had severely affected facets in the two upper levels. But I don't care. I go evaluate them by segment, and it doesn't matter, because the alternative would have been to make a 3-level fusion, and he's definitely better off with at least the lowest one mobile, and that will reduce the risk of having an issue on top of the two fused ones. But of course I cannot guarantee, I just try to reduce the risk. And if you have a patient like the one you mentioned with a deteriorated 4-5, suitable for disc, and then a 3-4 with facet joint arthritis, we know that if I get that mobile again, it will be painful from the joint. And if I put some odd rods and things like that, it will be like an A-lift. The only thing is that the patient has been open from both anterior and posterior and had much more of a trauma. On the other hand, if next level is already painful, to give a provocative discography, it's already painful, then I would put a disc there as well. But if not, I think the chances that it will be painful is so low So it would be not ethical to treat that in just out of security reasons or whatever. Did you get me?
I got you. Yeah, I completely got you. It's basically about, you know, the facets and the anatomy in the back, and I completely agree. And, you know, one of the questions that I get a lot too, and Maria, I think you could probably weigh in on this and say, yeah, I pretty much know what you're gonna say, but how do we keep our facets healthy? You know what I mean? Like, say we have had a few ESP, and we know that there's some very light facet arthritis kind of happening at a level below or a level above. How do we keep those facets happy?
I would say that this is the sort of the main thing in all the work we do here, that all the patients, when they come to me, and I have been here 16 years, and I see a lot of patients during the year and all these years, they have all brain back, the muscles in the back. And that gives a tension, hypertension in the erector spina, the big muscles in the back. And if you do that over the years, you still keep on training and doing rehab for your back issues or back problems, that will give also pressure on your facet joints when you have a disc degeneration. So when they come, I always tell the patient that today, when you come here for the first visit, we don't know what gives you really pain. Of course, they've been to Svante and the x-rays and so, but the pain that they have in the soft tissues, in the muscles, is great. It's a lot of pain in the muscles. And when they start to do stretching in the back, instead of strengthen the muscles there, it's such a big difference. And they also release the pressure of the facet joints. And in the lower back, they always have a bad posture because they have then hypertension in the back and they are weak in the front. And I have high-level athletic people that don't have enough strength in the stomach muscles, although they go and they look like Mr. Muscle Man, but they don't have that kind of friendship between the back and the front. That is always wrong. And they don't have the body posture to stand and sit and lie in a positive way of what they have with this disc degeneration. And when they get my exercises and I give them no at the gym with this and this and this, all of a sudden they come back after a month or so and say, well, you know, I feel like a little softer and I'm more flexible and things like that, because they haven't trained the back and also give some release of the facet joint. So in my point of view, I would say that posture is very important, not to tilt and increase your lower back. And to learn, all patients, even men that maybe not even so often train the floor, the pelvic floor, and learn how to move separately your pelvic, because they come, I call them like they come, sorry, they come like a fridge. They are all together.
Like a box. Like
a box, because of protection of everything during the years. And you can really knock on their glutes, you know, to the butt. And they are so tight in your the hamstrings. So they are like in a block like that. And slowly you have to give them equipment to learn how to have some body postures, sitting, standing, lying. So to avoid the facet joints pain as much as possible is to stretch the back, strengthen the stomach, stretch the glutes, stretch the hamstrings. They are very involved with lower back pain, and people don't think about that. But that is the most common comment after the surgery, like, I couldn't believe I'm so tight in my hamstrings. So everything is connected.
I think I use a pedagogical way when I see patients first time. I said, how long have you had low back pain? Let's say 7 years. Okay, your spine muscles went to training camp 7 years ago. It's been on training camp 24 hours per day, 7 days a week since then. Do you think they are weak? you feel fatigue in your back, but that is not because you're weak. That's because they never relax. And then I prepared them for meeting Maria, because then I said, we have to do something about it. We have to prolong them and pick up everything that we gain in back, we pick up with the shortening of the abdominal muscles, because they didn't go to training camp when you had your low back pain. So I use this as a model to prepare the patients to do this, because this is not a lazy person's surgery. If you're gonna, you can have a fantastic result from this surgery, but you have to go all in.
Yeah, and then it's amazing that during the 16 years that I worked here in this clinic with Svante, that, and I have maybe, I don't know, 200 patients a year that I train and I take care of like that. I haven't heard one say that they train like this. And they are so surprised when I show them on a model how the biomechanical way works in the lower back, that nobody told them, and they have been visiting all kind of healthcare people. So they get an aha like that the first visit, and then they get also, it's important that they understand what is going on there when you move and when you exercise, and nobody so far has trained in that way what we are saying that they should do. So it's really surprisingly, but
I'm also the spine guy for the Swedish Olympic Committee, so I see a lot of our top athletes. Mostly they don't need me as a surgeon, but it's so obvious how unaware their trainers are of these mechanisms, and they need maybe to do a lot of squats or whatever, and they don't have the abdomen for it. So they just hang in their facets and they're strong in the spine muscles, but they don't have the abdominal muscles for that work. And then they get pain and they can't do their athletic sports. And it's many of them, you just change training and thoroughly. They live on their body, so they listen to you. And if you just change this, in 2 months you hear back, well, the problem is gone. So it's very encouraging that this is probably the way our spine should work.
but it's also important to know that it goes like everything else. It's like sort of fashion in rehab and in training and exercises. I'm so old that the Pilates ball was called the Bubat ball from Germany, the treatment if you'd have, a stroke or something. And now all of a sudden it's in the German, I was Pilates ball, and I said, well, so, but, if you understand your anatomy and you understand the body, this is the way to go. It's clear. And the patient gets they understand the situation.
And this means that we don't want our patients to sit on a Pilates ball because they increase lordosis to stay there. Otherwise they fall off. So
it's
I say, make a hole in it, I say, if they have one.
Yeah, it's really to stick out the nose to say that, but it's experience. I mean, we experience that they just give the hypertension in the muscles instead of giving the stretch that they need, the muscles.
I guess my last question, and a lot of people agreed with, was when this person from the group asked us, because you said after 2-3 months that after 3 months people can go skydiving or one, but we know that some patients take much longer, and I guess nobody can really figure out why. I don't know if you can figure out why some people will take 3 months or 6, and it may be because their anatomy, or maybe they're bad patients, or maybe they've stayed on a couch through most of their recovery, and we know that's the worst thing to do as well. But what maybe, and Maria, I wanted to ask you is, what one exercise people shouldn't do for their backs? Because I think that'd be good to get people to watch your videos. And then
okay, they give before the surgery, they need to leave out some exercises. So they should not increase the lower back, which is one of the worst one is knee bending. So you do a squat. with some weights, and that all the patients have done. So no squat, and they can't do any plank. Do you say the planka?
Yeah, plank.
Yeah. And they are not allowed to do any exercises with the Pilates ball, and no shins. You know that when you come up and you hold yourself and you squeeze, because
Well,
then you use your hip flexor too much. And they are not allowed to do marklift.
Well,
Mark lifting, or what you call a ground lift.
Ground lift, when you take the bar up the floor,
Yeah.
because then you always shift over to lordosis too.
Yeah.
I think in the bottom line in this is, don't do any exercises that creates lordosis in your spine. Try to keep it straight or in doubt, slightly forward when you train.
Yeah.
What about that patient that has had surgery? And we have one. He was, I don't know if you remember that show. I don't know if you guys got it. It was called American Gladiators, and he was one of the hitmen on the show, and his name was Nitro. You remember that show, American Gladiators, where they
we had it in Sweden with Swedish athletes. One of our patients actually was the female torturer. She was she hit the
He was the male torturer. He's the greatest guy, because he's one of these self-improvement guys. He does all these podcasts all day long, and we post him sometimes on our group as well. And he had a 3-level done here in the States. He had 2 pro disc and a fusion at the bottom. But and he suffered for a while, and he had some issues. And I know he won't mind talking to him. But he's now deadlifting. I think he's 8 months out now. Now he's deadlifting about 300 pounds. So about 150 kilograms. Is that okay?
Yeah. As long as you keep your spine stable, as long as you load it the way God intended. And that means without lordosis. I mean, I let my patients go parachuting. You can imagine soon after surgery, after 3 months, you can imagine the compressive forces of that. But as long as they don't land in lordosis, I think that is, our spine can take enormous loads, whether fused or discs or whatever, if it's centralized, the load is centralized, and it's not bent over backwards.
Yeah. And that is also important. And for the patient, it's difficult to understand what gives me an increased lordosis. And that's why it's so important to give them examples of when you do this, and when you do this and this at the gym, because they don't have the mind of, oh yeah, that's right, and maybe it's increased lordosis when I do this. They don't think of that. They think of the muscle that they are training, maybe the biceps, but in a position where the lower back is involved. So it's important that they come and to explain on their body what they need to think about. And when I say no, 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 no to this, well, I cannot do anything. And then I teach them this and this you can do. You can train all the body without increase your lower spine there and have the pressure of the joints and so on.
I think we have an issue with our patients to make a little brainwash, because we are all brought up from the old folks. Stretch up, boy, otherwise you're going to have low back problems, or you look lazy or whatever. And this culture is very non-ergonomic. And I think Maria and I, we are not nagging on our kids if they hang on the table. We say, keep up the good work. It's a game shifter, but I saw in this group a lady that said that she was only fine when she was lying on her side in a fetus position with a pillow between her knees. That's exactly what we tell our patients to do, because you stretch your lower back muscles. And that was the position she, out of herself, as many patients do, found was best. And how come would that be if lordosis is so great?
Right. Yeah, I mean, that's definitely a big tip. Sleep on your side with a pillow, and I've been doing that for years, and that's where I usually feel my best at. And it's probably why my shoulder gets a little sore sometimes. I don't have much else. I don't know if there's anything else you guys wanted to talk about. I think we talked about distraction pain for the last, say, 10, 15 minutes. Kind of that was kind of the topic here, was how do we prevent distraction pain? And I think that whole last 15 minutes discussion was there. But if you guys wanted to add something, feel free.
distraction pain.
Distraction pain, yes, that is a pain. That is a pain that the patient then obviously have then after the surgery. And I would say my patients are doing for a month before the surgery my exercises that they strictly do. And they prepare their body and of course the muscles in the back of becoming higher, which means you have to stretch the back and strengthen the stomach. So they are fully aware of what kind of exercises they are going to do afterwards. And so like Svante told me, that we have an exercise which is called the frog, where they put the legs the same day after the surgery, hours after, to start on doing the stretch for the back muscles. They are now in shock of becoming more stretched out, because you can prepare the body, but you can't completely prepare the height that you now have in your segment. And then the patient needs to do this strictly very often, several times an hour. So I wouldn't say that have so much distractions pain. And I get more and more the years that comes that I give exercises in the gym after a month or so. And that is because they are so well prepared just before doing these exercises, and also immediately starts to do the stretch afterwards. So the distraction pain that these patients in this group might have, I think, is because they haven't done a pre-protocol, tough like we have here, and afterwards maybe not enough, maybe too early to start to do the no exercises that I have, because I'm very particular that they are not allowed to do these exercises until I suggest them to do, and that takes several months, because the body needs to accept it, to realize that this is a new situation. I'm higher and more tight in the back, and I need to combine that with my stomach muscles to adapt. And that new situation takes different time for different patients, but they are very prepared before, and then they do exactly the same afterwards. So I wouldn't say that distraction pain is a big issue here.
I'd like also to add that I've understood from the group that there is different tempos of restoring all the capacities and getting rid of pain. And of course, we see that as well. I just think that with this program that they have in advance, everything is more speeded up. But of course, we have a spread. I see all my patients after 3 months, and as you've seen pictures of, Jamie, I have people sending me pictures from heavy downhill skiing 2 months after surgery on the one side, and on others, when I see them at 3 months, they have a lot of muscular issues still. So it varies also with the patients that we treat here. But I think we have shortened the convalescency quite a bit by this pre-op program.
Yeah, because it depends on what kind of patient and what kind of muscle they have. How soon do the muscle listen to the new situation for them? It's a vary, but yeah, it's a vary. But I would say they become better and better, faster nowadays.
One patient that say, and I'll example, I know say like Peter, for example, he had tremendous amounts of pain for 2-3 months, and he was on a high script of gabapentin. Is there, but if I took 3,000 milligrams of gabapentin a day, I don't think I'd be able to get out of bed personally. I took 400 milligrams one time, and I felt like I was in Neverland.
But
so
he was used to it prior to surgery. He had it a lot prior to surgery first. So
right.
I think he was used to it. But we were, of course, approached by him by his leg pain. But we know for certain he had nothing compressing a nerve in the spine. We knew that he was extremely short in his gluteal muscles. So that was the reason, because the nerves coming out from the spine has to go through the gluteal muscles. And if they are too short, they get this type of sciatica. And that is what he had. And now we both saw him today. Now he's off the medication since quite a while, and he's had no pain in his legs, and that means he has managed to resolve the issue with the cramping, contracted gluteal muscles. And he said that too. He was very movable now.
Sure, sure.
So that is, if you run into problems, we do this so much, so most problems we've heard of, but one of the most frequent problem is that the patients doesn't get their glutes stretched enough. Even if they've had the program prior to surgery, they do the lumbar muscles post-surgery, but then when they come to Maria after months, the glutes are lacking little. They're lagging, and they have to concentrate on them for a while.
Yeah. And most of them, they get rid of that by increasing the glute stretch. I would say 9.8 of 10, all kind of patients, they get better. There are maybe once in a while that it instead increase, but it's very seldom that the irritation gets even worse, but that they are so few.
Do you use anything else besides gabapentin, Dr. Berg, that seems to work? I mean, for those issues out of the hole?
I actually rarely use gabapentin too, but he has had so much leg pain, and normally on patients that sees Maria a couple of months after, before I see them for checkup, or when I see them at checkup for 3 months, if they have still muscular issues, even if they're not lazy, I give them something in Sweden called Paraflex. It's something that lowers the tension in the muscles a little. No connection to Valium or benzodiazepines or so. It's a totally different substance. It's not addictive, but that helps them a little. They still have to do the work, but they can sometimes move on easier through this.
Okay. Yeah, I mean, some of the things that we always recommend is magnesium, you know, different types of magnesium, and that seems to help relax some things and whatnot. But I guess I was wondering if there's anything else that you guys recommend. But we've definitely gone over our hour, which I suspected we might have, wasn't sure, but as always, it's been fantastic. So a patient saw this today. He's very interested in coming to see you and have you treat him. How would he get in touch with you, Dr. Berg?
Yeah, through my mail address, svante.berg@spinecenter.se. I think you have it in your files.
We do, but you know, some people want to write it down during the video, so we always want to offer that. Anything else you guys wanted to talk about today before we sign off?
You probably notice that we are fairly enthusiastic for this. I mean, once you push the button, we can keep talking forever.
Yeah, I've definitely noticed that from talking to you for quite a while here, and that's what we love about the group, and especially with you helping us out, and we really appreciate both of you, that's for sure, and I do as well. Thanks again. Let me hit the recording off, and then we'll talk here a little bit.